everybody, listen up. I'm going to give you the lowdown on small bowel obstruction in just 4 minutes. It's easy to understand, you don't even need to be a surgical trainee. The small bowel is a long flexible tube starting at the duodenum and ending in the ileocecal valve. Food is pumped through it by ways of peristalsis. Problems can arise either when the pumping action doesn't work properly, an ileus, or when there is a mechanical obstruction, i.e. something physically blocking the tube. Blockages can originate within the tube, i.e. intraluminal, for example a food bolus or even a gallstone. Blockages can be within the pipe's wall, i.e. intramural, for example a stricture or tumour. The blockage may be outside of the pipe altogether or extramural, for example a hernia, adhesions or a large aortic aneurysm. Worldwide, the commonest cause of SBO is hernias, and in the UK, adhesions following previous abdominal surgery. Patients may present with complete or partial obstruction. The 4 cardinal features of obstruction are vomiting, abdominal distension, absolute constipation, and colicky abdominal pain. Vomiting may be a late sign if the obstruction is low rather than high. Clinically, the patient may appear unwell and dehydrated due to the pooling of fluid within the bowel, i.e. third space losses. Investigations include a plain abdominal radiograph, which will show dilated centrally placed small bowel loops, identifiable by characteristic valvulae conniventes. 3 centimeters is the upper limit for the diameter of normal small bowel. A CT is sometimes performed, particularly if there is a concern that the obstruction may be secondary to a tumour or bowel may be strangulated. The management of SBO initially involves resuscitating the patient with intravenous fluids while decompressing the bowel with a nasogastric tube. This is sometimes known as drip suck. The NG tube should be wide bore, i.e. Ryle's tube. A urinary catheter is useful to guide fluid resuscitation. This conservative approach is often successful in the case of adhesional SBO. It is reasonable to attempt this management for up to 72 hours. If, however, the patient deteriorates or SBO persists, then further imaging is indicated and surgical intervention may be warranted. Signs of peritonism, i.e. guarding, rigidity, rebound tenderness and tachycardia, with or without raised white cell count and fever, suggest that bowel may have become strangulated or perforated. An arterial blood gas may demonstrate a metabolic acidemia with a raised lactate. This is a surgical emergency requiring a laparotomy. Indicators of resolution of SBO include reduction in abdominal pain, vomiting and distension, and the passage of flatus with improved appearances on serial abdominal radiographs. In conclusion, SBO may be complete or partial, simple or strangulated. The commonest causes are adhesions and hernias. Clinical appearances include vomiting, absolute constipation, abdominal distension, and colicky abdominal pain. Conservative management is with NG tube decompression and IV fluid resuscitation, usually for up to 72 hours. Laparotomy is urgently indicated if there are signs of bowel strangulation. Thank you for listening.